Bugün size tanımı, klinik özelliklerinden biraz bahsedeceğim ve daha çok etiyolojisi üzerinde duracağım. Tik bozukluklarına baktığımız zaman çocukluk çağının yaygın görülen nörogelişimsel bir bozukluğudur. Tik'in tarifine baktığımızda vücudun herhangi bir yerinde görülebilen, birden ortaya çıkan, hızlı, yineleyici, düzensiz motor hareketler veya seslerdir. DSM-5'te sınıflandırmasına baktığımızda bir takım değişiklikler yapılmıştır DSM-5'teki sınıflamada. Gelip geçici terimi yerine transient yerine provizyonel, kronik yerine persistent, Tourette sendromu yerine Tourette bozukluğu, başka türlü adlandırılamayan Tourette bozukluğu da tanımlanmış tik bozukluğu ve tanımlanmamış tik bozukluğu olarak sınıflandırılmıştır. Tanı kriterlerine baktığımız zaman hızlıca söylemek istiyorum. Geçici tik bozuklukları tek veya multiple motor veya vokal tiklerden oluşuyor. Bir yıldan daha kısa süreli olduğu zaman geçici tik bozukluğu diyoruz. Kronik dememiz için hem motor tikin veya vokal tikin olması lazım. İkisinin birlikte olmaması gerekiyor ve süresinin bir yıldan daha uzun süreli olması gerekiyor. Tourette sendromu tanı kriterlerimize baktığımız zaman da 2 ya da daha fazla motor tikler olacak ve en az bir vokal tik. Bunlar eş zamanlı olmak zorunda değil ve bir yıldan daha uzun süreli olmak zorunda. Başlangıç yaşımız 18'in altında olması gerekiyor. Klinik özelliklerine baktığımız zaman tikler basit ve kompleks olarak ayrılmakta. Basit motor ve fonik vokal şeklinde de ayırmaktadır. Hepimizin bildiği gibi basit motor tikler göz kırpma, yüz buruşturma, omuz kaldırma gibi tiklerdir. Basit vokal tikler öksürme, ses çıkarma şeklinde. Kompleks olan motor tiklere baktığımız zaman bunlar daha amaçlı gibi görünen hareketler ve birçok kas grubunu etkilemekte. Kopropraksi dediğimiz uygun olmayan davranışları yapmak şeklinde. Ekopraksi başkasının hareketini taklit etmektir. Kompleks vokal tiklere baktığımız zaman da koprolali olarak bildiğimiz sosyal olarak uygun olmayan dilde kelimeleri kullanmak, ekolali başkasının seslerini ve kelimelerini tekrar etmek, palilali de kendi kelimelerini ve seslerini tekrar etmesi. Tik özelliklerine baktığımız zaman dalgalı bir seyir göstermek ve isteğe bağlı olarak kısmen baskılanabilme özelliğine sahip. Çoğunlukla uyku sırasında geçmesine rağmen uyku sırasında da kısmen görüldüğü bilinmekte. Tipik lokalizasyonları var. Yani çoğunlukla vücudun birçok yerinde olmasına rağmen genellikle yüzde lokalizasyonu var. Tiklerin kamufle edilmesi söz konusu. Bastırılabiliyor. Tikler öncesinde duyusal fenomen dediğimiz, duyusal öncül dürtüler, hisler dediğimiz durum söz konusu çoğu zaman. Bu bir duyusal olaydır. Tik öncesi ortaya çıkan bir dürtü, gerginlik, basınç, kaşıntı ya da sersemlik gibi bir his farklı bölgelerde olabiliyor. Yetişkinlerin %90'ından fazlasında görülmekte. Küçük çocuklarda daha az sıklıkta %37, 10 yaşının altında da nadiren görülmekte. Tikleri tetikleyen faktörlere baktığımız zaman stres, kaygı, heyecan, öfke, yorgunluk bunları artırabiliyor. İstemsiz, uygunsuz yorumlar, belirli bir ipucu dediğimiz belli bir ırka, dine ya da etnik gruba ait bir kişinin varlığı ile örneğin tetiklenebilir. Tikleri azaltan faktörlere baktığımız zaman ince motor beceri gerektiren, konsantre olunan, duygusal olarak hoşa giden aktiviteler, mesela dans etmek gibi ya da uyku sırasında tikler azalabilmekte. Epidemiyolojisine baktığımızda geçici tik bozukluğu 2012'de yapılan bir meta-analizde en sık görülen tik bozukluğu 2.99, Tourette sendromu 0.77. Tourette sendromu için yapılan en son bir meta-analizde 0.3 ve 0.9 oranında görülmekte ve erkek kız oranı daha fazla, 3-5 erkeğe 1 kız oranında görülmekte. geçici tik bozukluklarına baktığımız zaman en çok gördüğümüz tik bozukluklar geçici tik bozuklukları aslında. Okul öncesi çocuklarda %22.3, ilkokul çocuklarında %7.8, ergenlerde 3.4 oranında görülmekte. En sık 3-9 yaşlar arasında başlıyor ve en şiddetli olduğu dönemde 9-11 yaşlarında. Genelde ergenlik döneminde şiddetinde bir azalma söz konusu olabiliyor. Yetişkinlik döneminde de Tourette sendromu olan bireylerin neredeyse 3'ünün belirtileri büyük oranda azalmakta ve 1/3'ünden fazlasında ise tik görülmemekte. Basit tikler genellikle motor tiklerden sonra başlamakta. Koprolali dediğimiz tikimiz 14 yaşında daha geç başlıyor. Bu da tikin seyri konusunda bir slide. Yetişkinlikte artmış tik ciddiyetinin öngörücülerine baktığımız zaman eğer çocukluğundaki tik şiddeti fazlaysa, daha küçük kağıt hacimlerine sahipse, daha zayıf ince motor kontrolü varsa bu yetişkinlik döneminde de artmış tik ciddiyetini gösteren faktörler. Şimdi etiyolojisinden bahsedecek olursak karmaşık bir etiyolojiye sahip. Halen nedeni tam olarak bilinmemektedir. Birçok genin birlikte etki ettiği, çevresel faktörlerle etkileştiği, semptomların başlamasına neden olduğu düşünülmekte. Halen tek bir spesifik bir risk faktörü bilinmemekte. Yapılan çalışmalarda genetik çalışmalara baktığımız zaman Tourette sendromlu bir ebeveynin çocuğunda Tourette sendromu olma olasılığı %10 ila 15 oranında görülmekte. Herhangi bir tik bozukluğu daha fazla görülüyor. %20 ile %30 oranında görülmekte. Birinci derece akrabasında Tourette sendromu olan bir kişi genel popülasyona göre 10 ila 100 kata kadar daha fazla risk taşımakta. Tourette sendromu ya da kalıcı tik bozukluğu hastalarının birinci derece akrabalarında tik yaygınlığı %25-41 bulurken genel popülasyonda bu oran %1 ile 1.8'dir. Oldukça yüksek bir oran bunlarda. İkiz çalışmalarına baktığımız zaman genetik çalışmalarda Tourette sendromu ve kronik tik bozukluğu açısından monozigot ikizler için %77, dizigot ikizler için %23 oranında oranlar bildirilmiş.
In a study which had been done with monozygotic twins, 16 pairs of monozygotic twins, the Tourette syndrome togetherness had been found 56%, and the other tic disorders had been found out to be 94%. We have many genes, just like a tree. Many candidate genes have been studied. Some of them have repetitions. I will pass them very fast. Especially in tic disorders, the dopamine receptors, D2, D4, dopamine carriers, the dopamine beta hydroxyls, which are assuming a role in dopamine carriage, monoxidil I metabolism. We had monogene works, and generally variation had been defined, especially in tic disorder and Tourette syndrome. These are the most relevant ones for tic disorder. Serotonin receptors have been also studied. Serotonin transport, the molecules had been studied. Tryptophan hydroxylase had been studied, and one of those sectors had been studied. The copy number variants has 4 genes, especially those related to Tourette syndrome and other tic disorders. These genes are studied for these disorders. TR family members, which have an effect in neuron growths. The materials were studied in this IMP-LV2. There are, of course, not things which we will remember, but especially 4 of them are important genes for this. When we look at the copy number differences, neurexin 1 is very important in the copy number differences. Presynaptic, it is a molecule responsible for presynaptic cell illusion. It had been studied a lot. Finally, in 2015, in World Tic Congress, it was one of the most important issues. Neurosynbin gene had been shown as candidate gene. Allylacetamin deacetates, catenoic content pin 4, they are deletions. We can see deletions and duplications. For collagen type 1 and alpha 1 in recent works, the application is very important. There were some connection works. One of the most important ones is studying the carboxylase enzyme. And we had found a mutation. This mutation is especially important in Tourette's syndrome etiology, and it showed the role of histamine, and this work is quite important for this. The genome diameter relation works studies have been made, genome-wide association studies, collagen type 26 alpha 1 and netrin 4 had been especially focused on in recent works. ADORA and acetylcholinergic receptors genes have been also studied, but we haven't found out very sound work. And they had been found related to Tourette syndrome. When we look at the Tourette syndrome in general, it's one of the very strong hereditary diseases. 80% of hereditary transition had been found. And when we look at the genome-wide works, the results are not enough. And they have a high repeatability. We saw that it's quite polygenetical, and many patients and thousands of genes are risky for Tourette syndrome. When we look at environmental factors, in prenatal side, smoking of the mother, alcohol used by mother, the overweight during pregnancy, weight gain during pregnancy, low birth weight, hypoxia, birth by cesarean, especially the exposure to androgens for males, the temperature regulation defect of hypothalamus, chronic maternal anxiety, and psychosocial stress. Also prenatal maternal depression, especially found out to be risky. Psychosocial stress, as I already said, are seen as environmental risk factors. In recent years, their relation with infections have been found, especially for it's think that there are some etiologic factors of post-phenexuous autoimmunites and more frequent AGBHS infections and increased antistreptosin, and they have ASO levels in TS. When we look at some case reports, we had found some other microbiological agents. We had found some infection factors. The immune response differences in TS, the pathological immunoglobulin G oligoglobulinal bands in the cerebrospinal fluids had been seen. Because of this, B-cell immune response-related damage had been thought. The decreased levels of T-cell regulators had been found in some patients. So another hypothesis is related to T-cell mediated autoimmunity. In patients with Tourette syndrome, the higher levels of interleukin-12, IL-12 and tumor necrosis factor alpha at the start of symptoms and during their exacerbation had been found, and excessive cell-mediated immune response had been thought as a hypothesis. In postmortem works in brains of 4 TS patients, interleukin-12 expression had been increased, and changes in natural killer cell functions had been found in viral response regulators and microglia functions. When we look at the pathophysiology of Tourette syndrome, the most important pathway is corticostriatal-thalamocortical pathways malfunction. Tourette syndrome is the result of the imbalance in the functions of the CSTC circuits contained in the basal ganglions, which regulate movement of the prefrontal and orbital cortex, providing movement in the brain, according to Leckman. It is imbalance in this function, and the result of this dysfunctionality or imbalance. Here, basal ganglia, basal cerebral cortex, thalamus, hippocampus, hypothalamus, and amygdala. Amygdala can be seen on this graph. When we look at the basal ganglions, striatum, it will be discussed a lot in neuroimaging work. Striatum, subthalamic nucleus, and substantia nigra are the parts of basal ganglions. When we look at the etiology, what kind of changes we have related to neurotransmitter systems? In Tourette syndrome, the most focused factor is dopamine hypothesis. One of the most focused factors it's thought that there is an extreme stimulation in this receptor, and it can be attributed to dopamine intervention or presymptomatic. It's suggested that either through a supersensitive dopamine receptor or after an anomaly in dopaminergic hyperinvention. In the studies with TS syndrome related to dopamine, because of the following reason, dopamine is especially focused on a reduced level of homovanillic acid in the cerebrospinal fluid of patients. The relieving effects of dopamine receptor antagonists had been shown through studies. The inducing effects of dopamine agonists on tics had been shown. Also, increased binding to presynaptic dopamine transporter site in postmortem striatum had been shown. Normal cerebral cortex, caudate putamen, glottis pallidus internal, glottis pallidus externa. In normal pathway, cerebral cortex to caudate putamen and glottis pallidus interna, and with the two receptor is implying to GPE. And in Tourette syndrome, it's going from caudate putamen to GPE and fallicus externa. There is an overstimulated stimulation, and from thalamus there is an overstimulated pathway. When we look at the GABAergic system, a deficit in cortical GABAergic inhibitory transmission may contribute to symptoms found in Tourette syndrome patients, and it was seen that these created tics. GABA-related genes have been associated with risk for Tourette syndrome and with symptom severity. In patients with Tourette syndrome, the serum GABA levels are reduced, and it was shown that medication affecting the GABAergic system had been shown to reduce tics. Altered GABA-A receptors and reduced density of GABAergic interneurons have been shown in Tourette syndrome. In magnetic resonance spectroscopy, GABA concentration had been measured in vivo with modifications. In vivo GABA concentration over the sensory motor cortex of children with TS has been reduced. GABA antagonists, when GABA antagonists had been seen, some tics had been generated in animal studies, and in lower anterior cingulate cortex, GABA aminobutyric acid levels in Tourette syndrome. Can you wrap up in 2 minutes, please? Over glutamatergic system, there are strengths in etiology. There is a thalamocortical circulation or circuit in hypoglycemic corticoamygdala, and the glumatic levels had been shown to be reduced. Related to serotonergic system, there are various differences. Serotonergic system, differences in the modulator effects of serotonin. Also, there are some serotonin transporter levels. Estophonic system had been especially concentrated on, in recent times, receptoric situation. In cholinergic system had been also blamed. Neuro monitoring works, as is the pathopsychology, is especially focused on the density in the anomalies in 3-4 metabolism. SHT1A density in the postmortem brain tissue of TS patients is especially taken into account, especially basal ganglions and corticosteroid fields has certain problems. When we look at the basal ganglions, the basal ganglia, especially there is a decrease in the volume. When we look at the prospective works related to OCD symptoms, the patients had been monitored and it had been followed until young adolescents, 7.5 years into adolescence. While there is a negative relationship between tic severity and caudate nucleus volume is childhood, there was seen no correlation between this. In thalamus, volume increase, volume decrease, or volume change had not been studied. When we look at the cortical gray substance, especially in children with TS, it was found the larger volumes of dorsal prefrontal and parietal occipital areas with smaller volume of the inferior occipital area in children. Change in the prefrontal frontal increase had been found. The greatest reduction in gray matter volume occurred in pre- and postcentral cortex and in temporal lobes. More recent study has shown a decrease in the cortex structure, and it was found that in surtux depth was less and gray matter thickness had been decreased because of this. The cortical thinning and volume change of the motor frontal and parietal cortex in childhood could continue until adulthood. Feim and al. Conducted a double concordance study on 16 twins with TS selected from the same population and found a high degree of hereditary factors in respect of cortical thickness and limbic areas formed from the right and left anterior cingulate and the left posterior cingulate. When we look at the commissural pathways, the mid-sagittal corpus callosum in Tourette syndrome patients had been found to be small or wide, but there aren't consistent findings in works. 121 patients had been compared with 158, 121 control and 158 TS patients. The mixed sagittal corpus callosum is smaller in children and it was larger in adults. We don't have many works related to limbic system, but the study showed that the hippocampus and amygdala volume was greater and smaller in adults. When we look at cerebellar system, it was found no difference, and also bilateral cerebral gray matter had been decreased. When we look at the full brain analysis, an increase in gray matter volume in bilateral ventral putamen and decrease in the left hippocampal gyrus volume had been found. When we look at the full brain analysis, the frontal cortex and basal ganglia had been focused on. And we look at the diffusion tensor imaging studies. Can you wrap up, please? In functional neuroimaging, the increased activation in neocortex, limbic area, striatum, and thalamus had been found to be problematic. The electrophysiological studies doesn't show any change. Most of them are normal. In recent times, a recent study on TS etiology, there was a study on the differences in neurocognitive function, and no consistent difference had been found, but especially for Tourette syndrome, especially from all KB and DB, it was think to be a phenotypic disease. So as a result, the pathophysiology involves corticostriatal thalamocortical circuits and abnormalities in the dopamine, GABA, glutamate, and serotonin systems. TS is considered a genetic disorder, but the genetics is complex and likely involves rare mutations, common variants, and environmental and epigenetic factors. The speaker is reading through the slides, so